Yep.
That time it worked?
Mm-hmm.
That's weird.
Yeah, we're live.
Awesome.
All right, well, sorry for the delay. So hospital in Illuminati was trying to stop us to go live. We have some technical issues, but we are online right now. I just need to make sure that we have a couple people who are going to be with us, that they are already doing the right thing. So let's make sure we send them the message. Okay. Well, good afternoon. It's May 7th. Today is our United Medical ACO weekly event. We are going to give you updates from the COVID-19 coronavirus and a couple of our topics with high ED hospital emergency department utilizers, what causes those issues, some of the healthcare related items with the anti-kickback and antitrust issues, and try to explain why these are bothering us. We are going to do our third session with our Cerner SPM group. Beste Crew, one of our senior client managers, will be with me, and we'll go through the AR flow. And then we have a book review with Dr. Jonah Gora. She's one of our physicians, and she's a board member at United Medical ACO. And hopefully try to finish all these by 1 p.m. So then we will have our second session for the Bariatric Friday with Dr. Erkan right after this. So I have Tanner Fuchs with me as usual, and he's gonna give us some of our updates from the COVID. But before we start, we do wanna actually thank our nurses. Today, this week is the National Nurses Week. We appreciate the work that they have done, they do for us. Being in healthcare is a difficult task, and our nurses are doing an extremely good job, and I am proud of them. And I do want to thank them for everything that they do for us. And as I discussed, as I mentioned, the RCM, which is the revenue cycle management, SPM, which is one of our PM systems with Cerner. And so, Tanner, if you can see, Dr. Gora is trying to get in, she wants to test, so you can manage that until I start. So, all right, so actually, now on the United Medical Services side, we mentioned from the core business of medical billing, business development in healthcare, care coordination, human resources, IT support, accountable care, and shared saving values-based agreements, and the revenue cycle management. Those are services that we have. So I'm going to have Tanner to discuss the vaccine updates. Tanner, I'm going to actually give you control. Let's try that so that you can actually, drive it until.
Sure.
I don't actually see. You don't have access to that, right? Are you able?
Doesn't look like it. Let me go ahead and see if I can move anything. No.
Okay. So we'll go ahead and start.
Go ahead. Okay. Yeah, no problem. So firstly, we just wanted to go over some of the updates we have around the vaccination rates here, both locally in Delaware as well as in the United States as a whole. So first, taking a look at the United States, we're continuing that downward trend of the amount of, or the rate of vaccination, kind of that daily rolling average that we're interested in. It's going to be really important when it comes to reaching herd immunity, that 75% threshold mark for the population that we've been keeping an eye on, especially as we get into the warmer months, into the summer. Now, originally, this was a target that we weren't sure we were going to be able to hit very soon. It was something that we thought might be coming towards the end of the summer, even if not the end of the year. But as vaccination started to peak there at that 4 million mark, as we had a bunch of different things going all in the same direction at the same time. We had the 3 vaccines that were being used for administration. We had a lot of education out there and public awareness for vaccine administration. So with the onset, as we've discussed, of the issues with the Johnson & Johnson vaccine and the kind of media craze around that, we started to see a little bit of a dip there. And now as we are progressing, we're hoping to see that this kind of level out, if not get back up towards closer to that 3 million per day mark. Although it might be a little tougher as we do head into some populations that are a little more hesitant with the vaccine. That might be kind of why we're seeing part of this drop off here as well. So we're seeing that reflected in Delaware as well. We've dropped about 2,000 doses per day on average since last week when we last met. And that has unfortunately bumped that pace to get to 75% up a month for both the United States as well as the state of Delaware. So whereas the United States was at about looking to 3 months to get to 75%, and Delaware a little bit faster at 2 months, they're both moved back up to 4 and 3 months respectively. So we'd certainly like to see this turn around and start to increase a little bit. Could be to a number of factors. Now, one thing to keep an eye on is actually this past week, we're starting to see more news and information come out for Pfizer biotech vaccine in particular. They're starting to get some data on the trials in the pediatric populations. So that could be another population that starts to move into the administration process of the vaccine in the next couple of weeks, if not possibly even a week or two. So that's going to be something to keep an eye on and could certainly help increase these numbers as well. So just kind of also taking a look at how the rate of vaccination is actually affecting the rolling average of new positive cases that we're seeing here in the United States. So in the United States, we're getting towards that 40% mark of the whole population being vaccinated. You can see here, it does say that about 6 places or 6 states in the United States have actually gotten to that 40% threshold of their population. So the United States as average is starting to get there, and we're seeing a continued decrease in the amount of positive cases on average simultaneously with the rate at which the vaccinations are getting to more and more percent of the population. So that's great news, and it's good to see that trend continue. So just some news that we have surrounding coming out here about the vaccines, in particular what we have here in the United States. A couple new interesting things coming out from data and studies that have been ongoing, and it's all data that we've been able to kind of share and discuss. These are all been topics that we've kind of brought up in the past. So one thing that we're all super interested in is if these vaccines are actually going to be effective against variants. So going forward, that's a big question mark, right? The variants are going to be something that are here, that are prevalent in populations, not just here in our local area, but the United States as a whole, and really the world as a whole. So as these vaccines get more and more used, we want to be sure that it's something that's going to be protective against new variants as the virus does mutate. So some new good information coming out for the Pfizer vaccine, that it is very incredibly effective, as the headline reads, against severe disease caused by 2 main variants that we're seeing, not just around the world, but as we kind of discussed a couple weeks ago, even here in Delaware. So the with clinical data, as well as now we're starting to get some real world data on that, we're noticing that the vaccines are going to be effective against the 2 variants. First one located in the UK and the other in South Africa. So that's great news. And additionally, this is something I kind of briefly touched on, is Pfizer vaccine is looking to be safe and effective for some of our pediatric population, specifically for children aged 12 to 15. So the FDA is expected to actually issue an emergency authorization for that population for this vaccine. So with the studies that had come out, about 2,200 children from 12 to 15 actually received the vaccine, and none of them actually contracted COVID. So that's good, even though we see here, as opposed to in that case, there was 18 who had received the placebo. That's really good news for the efficacy rate that we're seeing in that population, which is going to be, again, as I had mentioned, good for going forward and making sure we're getting more and more of the population vaccinated.
So, Tanner, yesterday there was something, another update that came up where they are saying that there's no way that a person who's vaccinated can be contagious or can actually transform transfer the virus to someone. And I'm just trying to find it. It's on my.
Yeah.
It
That's great news. And I know that was definitely an interesting topic as well. Right after a lot of people were starting to get vaccinated, the big question then was, what exactly does that mean for transmission rates? Is it something that you could still, if you're asymptomatic, have with the vaccine and then potentially spread? So if that's the case, then that's really good news.
I'll bring that up actually right now so that it is on my Twitter. So there it is. So medical expert. Oh, I'm not sharing, right? So
no, not yet.
You know, the thing is now,
seeing us.
I feel like I'm always sharing the screen, so then like I'm pretending like I'm already. So here it is. So the medical expert says that a vaccinated person cannot shed vaccine spike protein. So like this is really important. I think this is why we want people to actually get vaccinated, because it's not just for us, but for people who are around us, our families, our friends, our coworkers. So the responsibility is big, and I do feel like we have to go with what medical experts are saying, and we are trying to increase this awareness more and more. Now, I'm going to ask our senior client manager, Beste Kuru, to join us. Beste, if you can please come up.
Hi, Kemal.
Hey, welcome back. So since we did so well last time, we said we have to bring Beste again and get more education from her. So
Thanks for having me.
One of the things that we do is our goal in these sessions, we also want to be able to talk to our prospect clients, as we are the only authorized Cerner outpatient distributor from the SPM, our practice management standpoint. There is no other company who is utilizing it at the level that we do, and we want to make sure that we can actually provide the service to our other Cerner clients who are not part of United Medical. So we divide these into different modules, and we are going to ask you to help us with this today's module. So just to kind of see what we did, we went through the check-in, check-out process, revenue cycle management, Cerner SPM collection module with, this was with Muriel yesterday, last week, I'm sorry, SPM reporting with Carlos. And now, so you are gonna tell us about the AR workflow in SPM, right?
Correct.
All right, go ahead.
Hi, everyone. My name is Beste Kuru. Again, I've been on this session before. I'm a senior client manager at United Medical as part of the revenue cycle management leadership. Kemal, on the next slide, we see, actually, I wanted to use this image again because we have an established and long-term business partnership with Cerner, and it reflects in our systems and how we actually approach the work as well. This image really well summarizes how our systems are interconnected and how it helps to our core business, which is providing revenue cycle management services to medical practices. On the left-hand side, the practice management systems we currently have active are SPM and CPM, and we have been migrating those PDS clients to these two major ones. And on the right, we see the power chart, which is our electronic medical record system. And then for our reporting and communication needs, we use QuickBase as our main portal. Is that a heart? That's sweet. So I wanted to use this to just show the flow from that which starts with doctor's office check-in. The minute patient enters the office, they do have to provide their ID and health insurance information. And actually, you can see the types of mistakes or preventable types of denials we usually see from check-in and summarize there. And at the checkout, and well, the provider sees the patients, they have their diagnoses and everything. They enter their notes in PowerChart, our EMR system. And along with their medical notes, they of course diagnose the patient. They put in the procedure codes relevant for the visit, and then they also code the diagnosis codes. They pick the diagnosis codes. What happens next is from EMR system to our practice management solutions. There is a electronic connection, and the charges pass from EHR to PM systems. And that is the moment actually where AR team is more hands-on, and then the cycle of working on either corrections for failed edits or rejections or denials begin. At the systems level, we have a layer of filtering basically any types of mistakes that may prevent the system from billing the claim out, which we call failed edits. AR team at United Medical works on those failed edits. If there is none, then the claims go through the clearinghouse, which is TriZetto. We partner with TriZetto for EDI and actually RM services. And at EDI level, if the payer has set any rules to filter out any other types of mistakes that may have been entered, maybe because the insurance was terminated, maybe the patient provided incorrect ID, or they didn't have their insurance card with them, and then there was a typo. Any type of mistakes the payer has set as a rule at EDI level filters out those claims, and those become our rejections, which again, the AR team works on. If the cleanest claim, or once we work on the rejected claims, well, it goes back through the PM system and again through the clearinghouse, the claim makes its way to the payer, basically to insurance company. And at the insurance company end, the claim gets processed. It gets paid either in full or with some denials on procedure codes, and then the cycle begins again with the AR team. After payment posting team at United Medical posts the payments per the remits we receive through, again, TriZetto. Well, I know it's a lot, but I hope it was a good summary. And the next screen actually is just the same flow, just with the wording of how the claims go through either electronic and paper or paper channels. Majority of our claims go through electronically. Most major payers accept claims electronically through TriZetto. And some workers' comp or liability claims, and some smaller insurances we have to file with paper claims. But the flow is just like I summarized, very similar. We work on failed edit system level problems, EDI level rejections, and then for unpaid claims, we make sure that we make the necessary corrections per the guidelines, and then we send the claims back. In any time, if we need the input from either the provider or any type of information from the practice, let's say the office manager, we do use our portal, QuickBase, to communicate those type of inquiries back and forth. Similarly, practice may choose to put in some SR tickets for the AR team here, and then we will look into their questions as well.
So that's the way that I was explaining what's happening with the revenue cycle management. So revenue cycle management actually is kind of like the now fancier way of saying medical billing. Now, the reason we have to use this fancier term is not because we want to look fancy, it's just because it became a lot more complicated. So when we were to say medical billing, it didn't actually really explain the whole process anymore, because today medical billing is including our value-based contracts with the way that we diagnose, the way that we actually help our physicians from the AR workflow is one thing of getting payments, but another thing of getting the practice to understand their diagnosis, their like the certain utilizations that they can actually, while they're completing their payment process, they are helping their value-based contracts, so that just recently, because what we discussed with our AR team is that we want instant feedback from them to the providers. So then when they see certain pattern changes on the diagnosis and coding, they can alert them. So now I know you have a couple of screenshots from the SPM and Gateway EDI, and I was thinking, so if you can kind of help us to see like how easily we are able to see some of these things. And then yesterday in our meeting, you actually point out one of the patients, like it took like less than 5 seconds for you to find someone. So let's just look at those screen shots, so then you can actually explain them through that.
Yeah, thank you. So I wanted to include this screenshot from our clearinghouse, TriZetto. Again, we have been working with TriZetto for years now, both for our Delaware clients through the ACO and also nationwide for all of our clients. As you can see here, through the orange one, Manage Claims tab, what we are able to do is go into rejected claims. And this is just like the simple, flow I wanted to include. Of course, there's all the data accessible through Gateway, because all the claims, electronic claims, basically pass through this clearinghouse to the payer. And then the response from the payer, again, comes into the clearinghouse in the form of electronic remits. And from the Manage Payments tab, you see we are able to go into Manage Reimbursements and similarly access remittances to filter them out for any denied line items or whole claims, so that we can make necessary corrections on them. What is important here is SPM, one of our core practice management solutions, is actually very well integrated with our clearinghouse TriZetto, and are smooth and flawless. And yeah, just this slide, I wanted to include screenshots from the patient account and ledger screens. Kemal, because we work on these systems, I think it's very important how user-friendly a system is, both for the practice and also the revenue cycle team, both for, for both sides, because this is basically where we spend almost all our day, right? Looking into the accounts, correcting the claims, or making sure the check-in and check-out processes are smooth. Here on the left, yes, you have been working on the screen. Those are the demographics, the patient's, address, ethnicity, any necessary information where in the edit screen, you have guarantor information and all the details you can add. And on the right-hand side, you see the patient ledger with dates of services listed. And once you are able to actually expand the dates of services, you're also able to see the payments received or any work United Medical AR team has completed. And on the next screen, Kemal, I am summarizing one example of basically an AR denial correction, which then again ties to our decode, denial correction code system. What we do from AR perspective is whenever we flag a rejection or denial on the account, on the claim, we go into the account and we almost like flag them with these D codes. We call them D codes. These does, as you know, it just stays for denial. We also call them correction codes, because what we do on a daily basis is basically working on these denials to correct them to our best and per the guidelines knowledge and per our communication with the provider and the office. And then using these denial codes, we are both able to measure the productivity of our team members, but also we are able to use this as a good way to report to our clients what types of mistakes are on their claims, what types of mistakes are preventable, what are the top denials, what are the top rejections, and then we are able to summarize special reports for them, and we report on these on a monthly basis.
So basically, just going back to here, between SPM and CPM, two practice management systems that we use, which actually works with our EMR system with the full interface, and then us having our QuickBase as our database, which we customized this based on our needs in the last 15 years. So this is kind of like the way of our, the way that we are completing the entire process of what needs to be happening in the revenue cycle management. So these modules that we are doing each week, it's really helpful, not only for us to communicate this with our prospective clients, but also for our employees who are part of the revenue cycle management team, because some of these things, when we explain them again and again, it makes more sense for everyone. And then they do pick up, even I pick up some new stuff, although I'm the, I'm the one who have the copyright of those denial codes. Now there are new denial codes that you guys took over, and you guys added more to what we build, and that's extremely important. And I do want to thank you for joining us today.
Thanks for having me.
I'm sure we'll have you back again for other sessions. Thank you so much.
Thank you, Kemal.
Thank you. So we are going to go to our next topic of our emergency department utilization. Now, we want to give you some solid data and examples, and then we want our patients, our providers, everyone who's watching this, just have a better idea to understand what we are doing in the system here, in the healthcare system. So I asked Christian to join me today, so then he prepped some of these with me, and we try to share everything that we find from each week with our providers right away. So one of the big problems that we have these days is the emergency department utilization, and I'm going to actually just say that it's the hospital reality. Why we call it hospital reality is because there are issues that we want you, our people, our patients to be aware of these. And then now, today we are going to more focus on the avoidable ED visits. And this is, before I get to that, I do want to actually tell, in case you are our patients, and if you are watching this either now or later on, when you have an emergency, and if it's something that you don't need to call the ambulance, let's say, but you need to go, you feel like you need to go to the ED, your insurance companies, including Medicaid programs, they do have a after-hour nurse triage line. They help you with the process. So this one is from Highmark. So this is the number. So you have an emergency, you feel like you need to go to the ED. Well, don't go to the ED if you don't need to call the ambulance. Why I'm saying this? So when you go to the ED, you are going to be waiting for 3 hours in the ED, in the lobby. Someone is going to see you and then triage you, and then you are just going to wait. Unless you don't have the AC, and then you need to be in a cool place, and you want to go to the, luxurious hospital, lobby, fine. I cannot help you with that. But if you your time is important and you don't want to wait, call your nurse triage line. And then we are sharing the one that I have now on the screen is the Highmark, and this is their Medicaid program, and I believe we have MaryHealth as well, and I'll make sure that we include them in our next sessions. So please, try to avoid the hospitals as much as possible, so then they can help the people who really need urgent care. So now, as I said, Christian is my guest to explain some of these. Now, Christian, without giving the insurance name, we just want to actually explain this avoidable ED visit categories and what it means, and we have some patient examples. So explain to us what these are.
Of course. So as we've been talking about, we've been trying to make people understand that they don't always have to go to the hospital or the emergency room for things that they feel or conditions they might have. And so avoidable ED visits generally fall into 3 different categories. What classifies an avoidable visit? Well, first, is it preventable? Could we have done something in the past to help this patient so they don't need to have gone to the emergency room in the first place? Second would be non-emergent. So that means, was this an emergency at all? Did the patient have to go to an emergency room for this? And lastly, was it treatable by the PCP? Did the PCP have the equipment or resources that could have treated this patient, and so they didn't have to go to the emergency room? And these are all scored in different ways, and so we can determine whether or not we actually will need to go to the emergency room, and we can score them.
So this one, this slide is from last time. These are actual number of patients that we have. Like each line is 1 patient. So like patient 1 who went to the ER 39 times. And then one of the issues that we have is non-emergency service given in the emergency setting, right? So do you actually prep this one for me? So given this, you have this slide. If you can explain to me why we have these locations here.
Yeah, so let me explain this little table. So obviously on the left-hand side is the location, and then number of patients is the next column. So how many are being included in this table? Thirdly, we have the utilization. So this is the total number of times that these patients have gone altogether to the emergency room in this past year. And then the average visits is the breakdown for each utilization, how many the patients, the average that they've been seen. And so one reason we have these people here is because these areas generally have emergency rooms near them, which make patients more likely to go to the emergency room in these situations. Middletown specifically has an emergency center. And so we see that they have higher ED utilizations because patients tend to go to these emergency centers whenever they have conditions, just because the access is there. It's so easy to just do that. And yeah.
It's so convenient, right? So just like, they call that a hospital. So one of the things that I do want to also explain, the one in Middletown, there's a Christiana Care has an emergency department. They don't have all specialties available on site. So most patients who really need true emergency, they are being transferred to the Newark campus anyway. So like, for example, you won't find general surgeons when they're on the ED call, they're in the Newark. So the Middletown, so then they talk to the surgical, one of the PAs in the ED, and then transfer the patient anyway. So just because it's convenient doesn't mean that there will be any help. So please try to avoid these non-emergency services in the ED setting. Now, Christian, you have some patient examples, and again, without mentioning the insurance name, tell us what we see here.
Yep. Of course. So this is, let me explain. This slide shows you what we see. We have, I would say we work with an insurance company that allows us to see information on the reasons that patients go to the ER. And so at the top of the screen, you see 4 different rows: admissions, ER visits, avoidable ER visits, which is what we're focused on, and office visits. So this slide is talking about a patient's visit in the past year and a half or so. And what Kemal just circled is the avoidable ER visit. And if you notice in that box above, it has those 3 categories I just talked about, and they're scored. So this particular visit was 4% preventable, 37% non-emergent, and 59% primary care treatable. Now on the bottom, you see 2 boxes. These are actually taken from the documents about the patient's visit. And we see that this patient, the reason for visit, the chief complaint was an earache. And then we see that their plan was they just told them that what kind of issues they're having with their ear, and then they're discharged for home or self-care. And and when you read this summary about the patient, and then you see that it was an avoidable visit, we kind of get an idea about what these avoidable visits sometimes are characterized by. They're characterized by visits that don't need to be happen and things that could have been treated by a PCP. You're on mute for, yeah.
Sometimes I do mute myself, and then I'm not used to doing it, so I forget to unmute. What I want to say is that what we are sharing right now with this patient in the ER with the earache. So Dr. Janice Nevin, who is volunteering herself to reinvent the healthcare, what she's in her ERs right now, they are treating earaches. So that's one of our points that we are trying to say here. Like, these are non-emergency cases. ERs are not for earaches. So Dr. Nevin, I really ask you, I would love you to actually focus on the hospital settings and then make sure that you have a good handle on what's happening there. So this is a true case, and we are not exaggerating anything. These are actual patient snippets. So Christian, tell us about this patient.
This patient is definitely characterized as what we're talking about. So again, we have the same format. On the top, you can see the ER visits in the pink triangles going to the right, and then you have avoidable ER visits. And here I do want to say something. So this whole time that we've been talking, we don't want to say never go to the ER. There are definitely good reasons to go to the ER, but there are also many reasons why you shouldn't go to the ER, and there are things that you don't need to go to the ER for. So the orange triangles are avoidable visits. And you see this particular patient has gone to the ER many times in the past year and a half. If you go for the reason for visit, it's a bit verbose, but in the end, it is stomach pain and some nausea and vomiting. And then if we look at the square on top, it's 0% preventable. So we couldn't have predicted this or done something for it, but it was 58% non-emergent. It wasn't an emergency, and 23% primary care treatable. And it was enough to be listed as an avoidable care visit. And before I actually before we go into the next slide, I do want to say that someone watching this could suggest, oh, well, you're only presenting a few patients. This doesn't mean that it's going to be a big problem. It's not going to affect us badly in any way. But if anyone watched a couple weeks ago, we said that we showed that there are 85 patients in total who accounted for 25% of the cost of our total population. You don't need to have a ton of cases of this happening to be a big problem. You only need some. And that's one thing that we want to explain, is that even little things like this, it can all add up, and it can be a problem.
That's really important. So now I know we have two other examples, but we are a little bit struggling with the time. If we can quickly tell us about these two. That this is a patient with fatigue.
Yeah.
Right?
Yeah. So I think everyone understands the format here. The orange triangles are avoidable visits, and we see there are a few of them in the past year and a half. And this specific visit was 24% preventable, non-emergent, primary care treatable. Specifically, this person their chief complaint was fatigue, and this could have been treated by a primary care provider. We don't need to go to an ER to see this. Yeah.
And the next patient actually is pretty interesting. Go ahead.
Yeah. So again, orange triangles, avoidable instances. 78% non-emergent. It was an emergency. And when we look at the reason for their visit, we see that it was due to a headache. So these issues, try as much as we can to use our primary care providers. They're there for us when we have these things. And I think one of the main things that we're battling here, Kemal, and the reason we have this YouTube session or discussing this, is just to raise awareness. A lot of people just don't know. And so they go to whatever's convenient, which is often the emergency departments.
Well, that's exactly what's happening. And then what we are going to do is we'll be sharing these more and more frequently, because I think there's this perception that is around the hospital systems. They have the money, they get the big green, they charge 12 times more than anyone else charges. So, or 10 times or 6 times or 1,800% profit margin. So all these, I want our public to know that this is real. We are paying for this. So that's why when we find these issues and when we are working against these types of contracts with our providers, that's becoming more problematic for us to actually really work with them. So I have some other stuff that I'm going to share, but I have Dr. Jonah Gora. So yeah, Christian, thank you so much for joining me. And I'm going to ask Dr. Gora to turn her camera on. Dr. Gora, how are you doing?
I'm very good, and thank you for inviting me.
Well, thank you for being part of this. So why we have you today? Well, one day you just text me and then you said, I have a new book out. I'm like, oh, like she was writing a book. I didn't know. I got a little bit jealous because I'm, working on my book, but I'm probably 15 years behind. So, and then you were able to get yours done, and I was so proud of you. And next book, so we'll just talk a couple of those things.
Yes, I am a medical doctor, and I specialize in internal medicine. I grew up in the Philippines, and right after my medical school, I went straight to New York City to do my internal medicine residency training to further my medical knowledge. And from New York City, I came to Sussex County to put up my my medical practice. Currently, I have 4 medical offices in Sussex County. So the reason why I decided to write a book is to not just inspire the future medical students and the young doctors, but anyone who work hard toward their life goals. And the book tells my story and experience in what I went through setting up a practice in a small town like Georgetown and Seaford. It also relates the challenges that I experienced in converting my J1 visa to the H1B working visa, the challenges that I went through during the pandemic. Of course, I would be remiss it would be remiss if I would not mention Mr. Kemal Erkan's help as he chairs the United Medical ACO. He was very proactive, and I certainly mentioned that in my book, how United Medical ACO helped us in doing this daily webinars. So the book also narrates my story growing up in the Philippines, as it serves as a background on how I work hard and appreciate what I have, and being grateful to Sussex County for giving me a place here. So in answer to your question on when I started writing the book, I started writing the book around 3 years ago. And because of my busy schedule, like everybody else, it took me a while. So finally, I was able to publish it in April.
No, this is really good, and I knew your story overall, but when I actually was able to go through the book, I didn't finish it, but I will probably this weekend. But at least half of it I'm done. It's interesting to actually see it all together in a book, and also many people don't really understand the challenges that you have to go through, especially in the rural part of Delaware. So certain things that we have, the perception again is many people think that everywhere in the United States is just like New York City, and it's not. And then working in these rural areas, it makes it extremely more challenging. And I think I always say this, so you don't get enough recognition for what you have done for the medical society in the community for Sussex County, because of you, we have so many primary care providers in there. And I think that's really, I mean, I admire that a lot, and I thank you for doing that. But you know, the other thing that I just want to make sure, you and I, we were just talking last night, but you mentioned this before. So you actually, the loyalty you get from the book, so, well, many people may not know, and I'm just going to say this very quickly. So just recently, I became a board member at Brandywine Valley SPCA. Well, that was because of Dr. Gora, who put them in touch with me, and you know, I didn't know what she was doing before, and we are both big animal lovers. So, and as I started working with them, so you gave me another update related to your book, related to SPC, Brandywine SPCA. You said that you are actually maybe going to give the loyalty that you are getting from the book to SPCA. Is that the case?
Yes, my share of the book royalties will go to the Brandywine SPCA.
So that's really nice. So Brandywine SPCA is what makes them special and unique is this is a no-kill shelter, and that's extremely important to highlight, because one of the reasons that I didn't want to actually become part of an SPCA is because they were not keeping the animals long term, and this is a no-kill shelter, and we will be supporting them as much as possible. And I know, Dr. Gora, you do already more than I do, and I'll try to catch up on the support, and thank you for getting me in touch with them, and thank you for writing this book, and I'll try to promote it as much as possible from our side, because I think for new residents who are coming out of residency, they should definitely read the book, and I think you should finish the second one very quickly.
Yes, and one thing more, you know, my classmates in medical residency, after I informed them that I'll be putting up my own practice in a small town, they told me that I was crazy, and because I'll be putting up my own shingles here in Georgetown.
Yeah.
So, you know, this really serves as an inspiration and as a guide that we do have opportunities in small towns, and we also have options and choices. Absolutely,
absolutely. So, Dr. Gora, as a good friend, as a good client, as a good partner, it's always enjoyable to work with you, and thank you for joining us today. So what I'm going to do, actually, I'm going to close our session here. We had some other items with the hospital stuff, but we won't have enough time, so we'll do those next week. I have another session with the bariatric events, Bariatric Friday, starting in a couple of minutes. So thank you again for joining us, and we'll see you guys next week, same time. Thank you.
Thank you for your support. Bye.